Thank you, Professor Papis. Dear organizing committee, first of all, let me thank you for inviting me here. It's a great honor and pleasure for me to be with you at your excellent meeting. And today I would like to share with you a few thoughts about the recent developments in bariatric metabolic surgery. However, having said that, I realized in the last session that a lot of things has been already said and have been already said, so I'll go through different things pretty briefly, and I'll stop just at a few points I consider as very important. It's impossible to start a talk in Greece without showing an Olympic symbol, and as you will see, I'll try to utilize the symbol according to the 5 domains I dedicated to different parts of my talk. So the first one, just to have a look at the current situation where we are in regards of obesity and type 2 diabetes. You have seen a graph from Herman Toplak in the last session. I've got a different one, but it's very similar. There is Greece in the red, and there's the Czech Republic, and you can see that we are pretty similar countries in regards of obesity and overweight prevalence. But the data is not that new. You can see that from Greece it's from 2001 to 2003. From the Czech Republic it's 10 years old. But I presume that we are almost on equal sides of the table. Diabetes, and you know probably better than me because I'm a surgeon, so I've heard a lot of internists and other specialties different from surgical specialties, so I'm not that great in diabetes. However, having said that, as you can see, there is a prediction of diabetes prevalence for the next 20 years from the International Diabetes Federation, and it's threatening how many people are going to suffer from type 2 diabetes, specifically in Southeast Asia, Western Pacific, but also in Europe, about 20 million people in addition to the existing pool of diabetic patients. So those, here we are. That's the current environment, and we should do something with that, at least in my opinion. And one of the possibilities which I will try to show you today is metabolic surgery. I'm not saying, although I'm a surgeon and I'm in this field for several decades now, I'm not saying there's the only available treatment for type 2 diabetic patients, but what I would like to say is that metabolic surgery is one of a very good or excellent options for selected group of type 2 diabetic patients. And this is what I'm fully convinced of, and I would, if there was any discussion in the end, I would be very happy to discuss with you and hear your thoughts. Okay, so that's the current situation. Let's look at the IFSO role, because IFSO is also, IFSO European chapter is one of the co-organizers of the May meeting here in Athens, which I'm pretty much looking forward to, and I hope this is going to be an excellent meeting. So just to go one slide or 2 slides to the history, IFSO, International Federation for the Surgery of Obesity and Metabolic Disorders, started to exist in 1995 in Stockholm, and this was just a bunch of people there who were the founders of IFSO. Nowadays, it's the largest organization, surgical organization worldwide, and it has got, I think, so about 10,000 members, and there are societies and members from all over the world. It has got different chapters according to the continents, so it's a very active organization. The first meeting, which was held by IFSO World Congress, was in Prague in a year after its foundation. And it was an excellent meeting from many points of view, but the very important point of view of that meeting was that from the very beginning, IFSO started cooperation and collaboration with other specialties. So in Prague, there were already internists, obesitologists, there were diabetologists present, and there were others, nutritionists, psychologists, etc. So it started from the very beginning an excellent collaboration with the other specialties because, honestly speaking, in my opinion, excellent surgery is only 30% of the success for the patients. The rest is the team which takes care of the patient pre-op, but mostly post-operatively for the follow-up. So this is the most important thing. Of course, you have to have a surgeon who does a perfect job, but this is just a very, I think, 1/3 of the success. Anyway, the cooperation with EASO, namely EASO, went on and resulted in 2006 and 2013 in publishing interdisciplinary European guidelines. And they were published in the 2 journals, Obesity Facts and Obesity Surgery. And I'll show you on these guidelines in the next slide how they reflected and just mirrored the situation. So there was a huge evolution from 2006, where there was firstly published the guidelines, which were published guidelines for surgery of severe obesity. And there was a clear focus on weight loss of the patients. However, in 7 years, it changed dramatically. And the focus went to metabolic and bariatric surgery. The focus now is mostly and mainly on metabolic effects of what we are, as a surgeons doing with the patients. And this is, in my opinion, one of the greatest developments I have witnessed in the past 20-25 years. Okay, so stop about if so role and go to bariatric surgery. That's just a historical point of view. So the father of bariatric surgery may be considered Edward Mason from the US, and by his time, when he created the first gastric bypass or so-called vertical gastroplasty, this operation, the only criterion for success was how much did the patient lose. Nothing else. I mean, we were just counting kilograms, and I remember many congresses or meetings like that, where one and the other surgeon came and said, I'm the greatest, my patients lose 20 kilograms in average, and the other said, hey, you're bad, my lose 25 in average. And that was the only criterion. However, this changed to metabolic surgery, as I mentioned to you, and the internists and EASO reflected the same thing as IFSO did. So the primary indication coming from weight loss, bariatric surgery, came to the primary indication for operation, resolution and improvement of metabolic disorders, namely type 2 diabetes and others. And there is no anymore the only and sole criterion for success, the number of kilograms that are lost after surgery. Moreover, the focus and the important thing is how metabolic surgery can affect the diseases, type 2 diabetes and others. In which percentage and how long can lead this type of a surgery to remission or improvement of those diseases. So this is the current status. So metabolic surgery, in fact, if you look at it, includes also weight loss surgery, bariatric surgery, because by bariatric surgery we are decreasing the weight of the patient, thus the size of the fatty cells, and fatty cells and lipids are one of the most active endocrinologically and others active organs in the body. So it's a metabolic surgery anyway, but metabolic surgery really focuses on the metabolic disorders. So it includes the weight loss surgery, it includes the surgery for type 2 diabetes, for sleep apnea, and also you may consider it as a great prevention of some cardiovascular complications, and you will see the data you know probably from Sweden, published mostly by Sjöström and the others, and you will see how bariatric/metabolic surgery may greatly affect the metabolic disorders. Okay, now metabolic surgery, I have said that. I have shown you Edward Mason from the US, who was to start the bariatric surgery, the surgery for losing weight. And in metabolic surgery, there are two continents that are competing to each other. One is the European continent, and represented by Italian guys, and one is the Americas, the United States. So in Europe, I have to mention Professor Scopinaro from Genoa, Italy, who from the early 70s worked on so-called biliopancreatic diversion, and he basically developed one of the first metabolic procedures worldwide. If you imagine, biliopancreatic diversion is so far, honestly speaking, the most potent and most influential operation against type 2 diabetes. I'm not saying about the side effects. This is out of the discussion today, but what I'm saying is if you perform on a patient the classical biliopancreatic diversion, you'll get wonderful effects against type 2 diabetes. The other one was already mentioned here, and that's Francesco Rubino, and he just pulled the car a little bit further, showing how the metabolic surgery may act and what may be behind, what mechanisms may be behind the metabolic surgery. We will touch, or we may touch that later on. On the other side of the Atlantic, the US, Henry Buchwald, who is still active in lecturing and performing some procedures, published in 1983 a book which was entitled Metabolic Surgery. So basically 20 years before metabolic surgery stormed the society, I mean the scientific society, he already thought that there is going to be this kind of a discipline. And then another one whose nickname is Mr. Who Would Have Thought It, and that's Walter Porys, who published the classical article about treating type 2 diabetes with an operation. So that was the history of the development of the metabolic surgery. What I have said is that the metabolic surgery has got really long-term effects, and you can see I mentioned the cardiovascular diseases, and this has been published in JAMA in 2014, and you can see that the micro and macrovascular complications are in the surgical groups dramatically different, lower than the cardiovascular complications occurring in a control group of obese patients. And if you look at the y-axis, you see that the follow-up was done for 20 years. So it's not just a short effect of surgery. It's really a long-term effect of the surgeries. And even if we look at the number of cardiovascular events and mortality, you still see that in the surgical group, surgically treated group, there is, in 18 years, there is a lower incidence of the cardiovascular events, and of the fatal cardiovascular event, the difference is even greater, and it's statistically significant. So this supports the slide I started with, that the metabolic surgery may be used also as a preventive surgery in a sense of to prevent the number of cardiovascular events in obese people. This slide you have already seen, so I'll just jump over it and basically try to summarize with a few things, and then I'll jump to another field, also interesting. But I would like to tell you this is not a statement of a surgeon. This is a statement of both the internist obesitologists supported and being members of EASO, and no one can blame EASO being very fond of surgeons, but they agreed, the group of experts agreed, and then there was an official document that metabolic bariatric surgery is the most effective treatment so far available. I'm not saying that Herman is not correct, that in 5-10 years maybe we'll have some nice drugs which may come closer to the effects of, for example, gastric banding, which would be great and which I would have nothing against, because there is still hundreds of thousands people in each country, patients who are underserved by bariatric metabolic surgery. So I think so that none of the bariatric surgeons is afraid that he will lose his job. I mean, there is so many patients who are waiting for the treatment that if there is a pharma therapy which will catch even 100,000 patients and derive them from surgery, still nothing happens. A lot of other patients are waiting for the treatment. So, and one more thing, please. You should consider that surgical treatment of obesity has got a very low mortality. If you think of 0.3, even if 0.4%, and if you look at the mortality of patients who are undergoing, for example, laparoscopic cholecystectomy for gallbladder disease, for cholelithiasis, okay, and you look at the same age group of the patients, however, the gallbladder surgery is getting patients who are not morbidly obese or obese, they are probably overweight. And if you compare the mortality with those who are undergoing bariatric metabolic surgery, who are with great risks of the surgery, and you get similar mortality rates, what does it mean? It means that the bariatric surgery is extremely safe, because in fact it deals with much more complex, complicated, and risky patients than the lap cholecystectomy with similar mortalities. So this is just to have on our mind when we talk about bariatric metabolic surgery. Okay, we are coming to the last portion of our talk, and that's what's new, what's the next level of the treatment that is available. So, I have witnessed in the past many, many years a development gradually coming to a less and less invasive surgeries, less and less invasive approaches and operations. So let's have a brief look at both of these domains, and just to see what happened in the past few years in our streamings, I mean our surgical treatments. So let's look what we have now as a less invasive operations. Some of them are, of course, less effective. They are, or they stayed in investigational level, but I would like to mention them. And honestly speaking, there was a huge portfolio to pick up the things. And I didn't know what to do when I was preparing my lecture. And you have seen different new procedures already in the talk of one of our colleagues here in the last session. So what I did is that I looked at the procedures that we as an institution in my country, in Prague, Czech Republic, have at least some experience with. So first of all, there is a less invasive operations, the gastric stimulation. It works perfectly in dogs. Wonderful. It doesn't work that nice in humans, yet there may be some things that should be improved. However, the backup mechanism of the human brain is probably much better than the one from the dogs, because the dogs react fantastically on this device, not the humans that much. Okay, we also tried robotics to make the operations less invasive. Robotics is fine, And however, having said that, robotics is also very expensive. And so far, in my opinion, robotics in bariatric surgery is a nice tool to have, but it doesn't have anything to do with improvement of the results or with, let's say, lowering the complication rate. It's a good tool for the surgeons to play with, and possibly also to, not to be that tired after 5th and 6th operation. And the money, of course, the companies probably are pushing. But I'm not saying nothing against the robotic surgeries, but I think that at the moment, at least from my point of view, I can live without that. There were other devices, and in 2007, for example, the gastric bandings were developed in different way, and that was one of the gastric band that was developed by worldwide #1 medical device companies. We were those who firstly implanted that in my center in Prague to the humans, and it was good, but then after, about 2-3 years after that, the whole concept of gastric band declined. I'm not saying, again, the same with the robotic surgery. I'm not saying that gastric banding is a dead procedure. We still, in my institution, do about 10% of our yearly operations gastric bands. And there is a demand coming from the patients. We do not advertise that, but there is a demand coming from our patients, so we do that. Just for your information, in my institution in Prague, we perform roughly something between 500 to 600 bariatric procedures per year in the institution I work in. And there are 3 surgeons performing that in total. The other procedure, which was meant to be less invasive, and these 2 procedures, this one and the next one, please keep on your mind, because I will return to them back in a few slides, so just to make the comparison. So, laparoscopic greater curvature plication, okay, is one of them. I'm not saying it's the best operation under the sun, but in my opinion, it should have a place in the portfolio of bariatric surgery, metabolic surgery, and I'll tell you why once we'll come back to the other slide. So this is one of the procedures. Another procedure is, and that was, I think so, started mostly by John Melissas in Greece in 2014, and that's so-called laparoscopic partial jejunal diversion, which is, again, a simple operation, quote unquote. I hate to say in surgery simple operation, but it's simple compared to other bariatric metabolic procedures we have, and it just is composed of an anastomosis of the small bowel, okay, side-to-side anastomosis. So part of the food goes the old way, and part of the food goes the shorter way, put it this way. And I was surprised. We operated so far about 30 patients with that, and I was surprised under a controlled trial, and I was very surprised that the effect on type 2 diabetes is really excellent. There is no big effect on weight loss, which was not the primary goal, but there is an effect on type 2 diabetes, excellent effect. So this may be a procedure which is low invasive, just one stapler, fire, and go away, which may be feasible and which may be nice for the patients who suffer from type 2 diabetes and are not that massively obese. So they don't really need to lose so much weight, but they need to improve or resolve their type 2 diabetes. So that was about the operations. Now about the approaches. And again, there was a development. And as you see, this was the old way how to operate, a laparotomy. Okay, in a huge patient, it was a long laparotomy, like 1 meter probably, and you'll see a slide next to this. And you see now we are performing the operation through trocars that are 4 or 5 used, mostly 10 millimeters in diameter. So that's a difference, and that's a way towards really minimally invasive, hurting the patients the least we can hurt them. Laparoscopy, I think that we contributed in Prague to the development of laparoscopy in 1993, where laparoscopy was just starting around the world, when we performed the first laparoscopic placement of non-adjustable gastric band with my professor by that time. And we used a Dacron mesh, as you can see, for the banding. We closed that and sutured. And for the operation, there were no instruments produced by that time by the companies. So we used just a wire which was banded, and there was a hole at the end of the wire to grasp the band, the Dacron mesh, and to pull it behind the stomach. So those were really the first steps of laparoscopies. And this is the difference. Those are the patients. This is a patient we operated on via laparotomy, and this is a lady, the first post-op day after laparoscopy. So you can see that there is a difference. So this is the trend towards less and less invasivity. And a huge role plays endoscopy at this point. And you have already seen the endobarrier system, which is the approach, the endoscopy is really low invasive. The procedure not yet, because there is a huge barbed wire which has to be placed and anchored at the pylorus area, which irritates the stomach, and the device cannot stay there longer than 6-9 months, and there are some complications involved with this. But there is development going on, and we may face in a year or two a new device which would be much more gentle to the area where it's anchored. Let's say the blind way, in my opinion at the moment, was the nodes, the natural orifice, transluminal surgery. We also embarked and we operated on, we have got still the devices in my institution in the surgical ward, but not much happened. There was a huge expectations from nodes operating through organs in different parts of the body with a minimally thin instruments, but in my opinion, no big development happened since 2005 in this field. Okay, and now coming to the first operation, the laparoscopic gastric plication, which is an operation we like because we don't resect, we don't anastomose anything, we just hold together the stomach wall and invert the stomach. This is an endoscopic view, so this is the ridge which is just placed inside the stomach, and this is the volume of the stomach left. What does it mean is that the person can eat less, etc., etc. I don't have to repeat that. However, having said that, this makes sense also because there is the possibility now to perform similar, I'm not saying the same, but similar procedure endoluminally, endoscopically. And you have already seen the Apollo stitch here. So this is, the video doesn't work, but anyway, I'll try, no. Okay, doesn't matter. So you can create similar thing via endoscopy. And if this proves in the future that the results of the endoluminal or endoscopic, they call that sleeve plication, but anyway, semantics is not important, is close to the laparoscopically performed laparoscopic greater curvature plication. That may be the way where to go. So, remember the second slide I told you? That was the partial jejunal diversion, the two bowels together. And the same now comes to endoscopy, because now we are able to perform almost exactly the same procedure endoluminally, coming from through the upper GI endoscopy and through the lower GI endoscopy, placing two magnets, clicking the bowel together, and then there in a few days, in day 6, there is anastomosis. It's a pressure anastomosis, but it doesn't bleed, and it works. So once the endoluminal or endoscopic platform is more user-friendly, at the moment it's a painful procedure for the endoscopist to do, and the patient still has to be under anesthesia, and it takes several hours to do that, instead of 40 minutes via laparoscopy. But once the platform develops better, I mean, this may be another wonderful operation and procedure to be performed for type 2 diabetics who are not that massively obese. The transpyloric shuttle has been already shown, and I am not going to elaborate on that, but we were also involved in developing technically this thing. And last, or almost last thing, which I have big doubts about, but I have to mention that because it was also done on demand of our patients in a few cases, it's the aspiration therapy, which I have really big doubts about, but it's there. And some patients like it, and there is mixed feelings from the scientific societies about it. But anyway, and also what has been mentioned, and I'm really coming to the end of my presentation, was the gut microbiome, which I have no experience with. That's the only procedure I have shown I have no experience with. So maybe probably we can treat obesity, or at least part of the obesity, somehow by feces. So summarizing, there is an effort in the operation branch focused on low invasivity. In the approach branch, the technical developments are on the horizon, and the implants are going to be also more friendly. So there is no really better and long-term effective treatment than bariatric metabolic surgery, and there is no more powerful treatment for type 2 diabetes than that. Again, don't misunderstand me. I am not saying that this treatment is for each and every patient. The patient has to be selected. But if the patient is correctly selected, and there is a lot of patients who desire selection like that, the results are excellent. And I would like to, again, on behalf of Harry Papis, to invite you to the IFSO European chapter meeting in Athens, in your hometown mostly, in May this year. So, thank you for your attention.